The next topic is CA pancreas or carcinoma pancreas. Okay, so initially we'll discuss some basic points regarding carcinoma pancreas. So the patient presents with the most common site for carcinoma pancreas is in the head of the pancreas, and the patient generally presents with jaundice. Okay, along with jaundice, patient can have abdominal pain, and the patient may develop diabetes or anorexia, weight loss. Okay, so there is a patient around 60-70-year-old patient having complaints of jaundice with abdominal pain, and on examination the gallbladder is palpable. What is the most common diagnosis? The most probable diagnosis is carcinoma of the pancreas. Okay, what is the most common type of carcinoma of the pancreas? It is adenocarcinoma. Generally it involves the head of the pancreas, and we will evaluate the patient with a CECT of the abdomen, contrast enhanced CT of the abdomen, and which will confirm our diagnosis. Biopsy from the pancreas is generally not required, and CT is good enough for confirming our diagnosis. And in case if there is a malignancy and there is no metastasis, we can go ahead with the surgery. Generally the surgery is Whipple's procedure in head of the pancreas, and for tumor in the body and tail of the pancreas, the surgery is distal pancreatectomy with splenectomy. Okay, so the tumor in head is treated by a Whipple's pancreatic or duodenectomy, and tumor in the body and tail is treated by distal pancreatosplenectomy. Okay, so this is regarding CA pancreas. Now we will discuss it in detail. The most common type or the histological type is adenocarcinoma. Okay. Most common location is head of pancreas, head, followed by body, followed by tail. Okay, and the most common symptom is jaundice. Okay. Now, actually, the symptom as well as the treatment depend on the location of the pancreas, on location of the tumor. If suppose if the tumor is in head of the pancreas, then there is a possible involvement of, or there is early involvement of bile duct. Okay, so the patient will present in with jaundice. If there is tumor that is in the body or tail of pancreas, the patient will present with abdominal pain, weight loss, rather than jaundice. Okay, so symptoms generally is on the basis of location. Overall, if we'll see, the most common symptom is jaundice. Okay, so the symptoms are based on location, and in patients with head tumors, it is jaundice. In patients with body tail tumor, it is abdominal pain followed by weight loss. Okay, now the most common mutation in carcinoma pancreas is actually KRAS mutation, and this KRAS mutation followed by P16 mutation. This is very frequently asked. KRAS is the most common gene which is responsible for CA pancreas, and most common mutation in carcinoma gallbladder and carcinoma stomach is P53. Okay. Now, what all are the risk factors for CA pancreas? So the risk factors I have already enumerated. Smoking is a very important risk factor. Then hereditary pancreatitis or the chronic pancreatitis is also responsible. Hereditary pancreatitis. Hereditary pancreatitis generally occurs with the mutation of PRSS1 gene, that is a cationic trypsinogen gene. Then there is hereditary breast and ovarian cancer. Hereditary breast and ovarian cancer, and this hereditary breast and ovarian cancer occurs because of mutation of BRCA2 gene. Then there is HNPCC, hereditary non-polyposis colonic cancer. This is associated with Lynch 2 type of a disease in which CA pancreas, ovarian cancer or endometrial cancer and various other cancers can also be seen along with colonic cancer. Then there is ataxia telangiectasia. Important point regarding ataxia telangiectasia is that it is autosomal recessive. The other points, the other diseases here are autosomal dominant. So the autosomal recessive disorder which is associated with CA pancreas is ataxia telangiectasia. Okay. Then there is FAMMN syndrome, that is familial atypical multiple mole melanoma syndrome. And then there is Peutz-Jeghers syndrome. Now there is another question. Out of all of these, maximum risk is associated with a Peutz-Jeghers syndrome. Okay. So maximum risk is with, maximum risk of CA pancreas is associated with Peutz-Jeghers syndrome. Ataxia telangiectasia, autosomal recessive. Hereditary pancreatitis occurs because of PRSS1 gene. BRCA2 gene mutation can lead to CA pancreas. How? Through hereditary breast and ovarian cancer disease. Okay. So these are some questions, and HNPCC also leads to CA pancreas. Now, CA pancreas can metastasize to various organs. The most common organ it can metastasize to is liver. Okay. What is the tumor marker? The tumor markers are CEA and CA 19.9. And what is the investigation of choice? Investigation of choice is CT scan or CECT abdomen. With CT abdomen, we will also evaluate the resectability, whether there is involvement of adjacent structures or adjacent vessels like superior mesenteric vein, superior mesenteric artery. Involvement of superior mesenteric vein makes it borderline resectable. Borderline or locally advanced CA pancreas. And SMA involvement is superior mesenteric artery involvement is unresectability. Criteria is unresectable. Okay. Then what all are the barium findings? So the classical barium findings I'll enumerate first. Then the classical barium finding is antral pad sign or reverse 3 sign of Frostberg and widening of C loop of duodenum. I'll show you the diagram later on, but what happens is that this is a duodenum here. Because of this mass here, this C loop of duodenum widens. Okay. And there is a reverse 3 sign. There is compression here and here. So there will be a reverse 3 sign like of a pattern, which is also known as antral pad sign. Okay. And suppose there is a CA pancreas which is involving the bile duct also. So there will be a dilatation of the pancreatic duct. There will be a dilatation of the CBD, and in between there will be mass. Okay. So this is classical double duct sign which is seen in CA pancreas or ampullary carcinoma. In ampullary carcinoma, there will be dilated CBD as well as dilated pancreatic duct. So double duct sign is seen in CA pancreas or ampullary carcinoma, dilated CBD and pancreatic duct. Okay. Generally seen on, it can also be seen on MRCP or ERCP or CT. Okay. Other signs can be rose thorning, mucosal irregularity, or scrambled egg appearance. Now we have diagnosed that the patient is having CA pancreas. If we have diagnosed, then we'll have to plan the patient. The treatment of choice is surgery. Okay. So the treatment of choice is surgery, and the surgery is, if the tumor is involving the head of pancreas, for head tumor, the surgery is Whipple's procedure, Whipple's pancreaticoduodenectomy. or a pylorus preserving pancreaticoduodenectomy, which is also known as Long-Meyer Traverso procedure. Okay, and in case if the tumor is involving the body and tail of the pancreas, then the treatment of choice is distal pancreaticosplenectomy. Okay, radical distal pancreaticosplenectomy. Okay, RAMS is a procedure. This is radical antegrade modular pancreaticosplenectomy. This is a technique of pancreaticosplenectomy, and how we are doing a pancreaticosplenectomy to remove maximum lymph nodes and better outcomes. We perform the procedure using a RAMS technique, and for your point of view, the thing that is important is RAMS is used in CA pancreas and RAMS is used in body and tail tumor of pancreas. Okay. Now, chemotherapy after surgery, in case if it is a locally advanced tumor before surgery, we can give chemotherapy. Chemotherapy is gemcitabine based. Nowadays we are using FOLFIRINOX also, which is showing very good results. FOLFIRINOX chemotherapy is also being used nowadays. Okay. Now, regarding the pancreaticoduodenectomy, I will discuss the procedures with you. Before that, some important questions. What is the most common complication of pancreaticoduodenectomy? So, most common complication of pancreaticoduodenectomy is a delayed gastric emptying. Okay, there is gastroparesis and stomach takes the ileus or the stomach takes more time to move. Okay. There are 3 anastomoses in total, and out of these 3 anastomoses, that is pancreaticojejunostomy, politicojejunostomy and a gastrojejunostomy, maximum risk of anastomotic leak is with PJ or a pancreaticojejunostomy, because pancreas is generally soft and fragile. It does not hold the sutures well. Okay. And the most common cause of death after pancreaticoduodenectomy is cardiopulmonary complications. What is the most important predictor of survival after surgery? It is R0 resection. R0 resection is actually resection with negative margins. R1 resection is resection with microscopic positive margin. And R2 is resection with grossly positive margin. Okay. So if there is R0 resection and the margins are negative, then that is the most important predictor of survival. Most important margin is the retropancreatic margin or the uncinate margin. In the anatomy portion, we have seen that the uncinate process is very much along with the superior mesenteric vein or the superior mesenteric vessels. So that margin or the margin which is behind the superior mesenteric vein is the most important margin. Retroperitoneal or the uncinate margin is the most important margin. Now, we have done a surgery. Now, what is the survival or the stage-wise survival? In stage 1 and 2, the survival is generally 16 to 20 months. Stage 3, it is 6 to 10 months. In CA pancreas, okay, and in stage 4, it is up to 3 to 6 months. So, this is important questions regarding surgery and CA pancreas. Now, This is antral pad sign. You can see here that there is this 3, the reverse 3 sign of Frostberg, or antral pad sign, and widening of C loop of duodenum seen in CA pancreas in barium. Now I will show you the Whipple's procedure. I will first make you understand that this is stomach, then this is duodenum, this is DJ flexion, and then jejunum. Okay. Now here there is pancreas, that is along with the C loop of the duodenum. In pancreas there is a pancreatic duct, and this pancreatic duct is joining the CBD in the head of the pancreas, and they both together then joins with the duodenum at the level of ampulla. In Whipple's procedure, we are removing the common bile duct, then we are removing the distal stomach, head of pancreas, and the first part of and then whole of the duodenum till the initial 5 to 10 centimeter of the jejunum also. Okay. Then what we are left with is stomach, here, body and tail of the pancreas, here, common hepatic duct, and here jejunum. Okay. Now what we want is to take this jejunum up and to anastomose the jejunum with pancreas, bile duct, as well as the stomach. Okay. So now what we are going to do here is we are taking this jejunum up. I'll show it with another color. And then we are taking this jejunum. We are first anastomosing this jejunum to the pancreatic duct. Then we are anastomosing this jejunum to the bile duct. And then after that, we are anastomosing it to the stomach. And then it goes in the abdomen. Okay. So here in total, there are 3 anastomoses. I'll first label them with some other color. 1, 2, and 3. Okay, if you will see here, the anastomoses are done in anti-clockwise fashion. Okay, and there the 3 anastomoses are pancreatico-jejunostomy, sorry regarding this, pancreatico-jejunostomy, hepatico-jejunostomy, and gastrojejunostomy. Okay, out of these 3, hepatico-jejunostomy is the most vulnerable and is most commonly the anastomosis which leaks out of these 3 is the pancreatico-jejunostomy. You can see this picture here also, that this portion of the stomach is removed, whole of the duodenum is removed, head of the pancreas as well as neck of the pancreas is removed till the bile duct along with the gallbladder. Okay, because cystic duct joins the CST to form CBD. So if we are resecting whole of the CBD, we'll have to remove the gallbladder along with the CBD, and we'll have to anastomose the common hepatic duct to the jejunum. You can see here, first we are anastomosing pancreatic, then second we are doing bile duct, then third we are doing gastrojejunostomy. So this way we will see this is anti-clockwise. Okay, this is anti-clockwise anastomosis. Now what happens is, suppose if we are not removing this portion of the stomach, we can, what we can do is we can transect the stomach here. Okay, and we are transecting actually at the first part of the duodenum, then we are removing whole of the duodenum. So this way, instead of gastrojejunostomy, we will be doing duodenojejunostomy. Whole of the stomach we are preserving, or we are preserving the pylorus which was removed initially. Now we are preserving. So this is actually pylorus preserving pancreatic or duodenectomy, also known as Traverso-Longmire procedure. This is also another variety of pancreatic or duodenectomy. This is regarding CA pancreas.